Okay, I think we'll get started. It's good to see everyone here today. The topic today is waiting for a kidney. I'll be speaking for half the time, and then Chris Nguan will be speaking for the second half. This may or may not have reached your radar screen, but it might interest you to know that BC has the distinction of the longest waiting times for kidney transplants in Canada. It's not even close, actually. We far exceed Ontario, which is second. This is, in fact, a lot of the data I'm going to show you today is from the Canadian Organ Replacement Registry, which is sort of a year-end type report that comes from the Canadian Institute of Health Information. And for the report 2006, which has data through 2004, you can see that the waiting times for a kidney transplant, for a deceased donor kidney transplant in BC, were over 5 years. Since Canada in general lags behind the United States and Western Europe in waiting times for transplants, BC more or less has the longest waiting times for a kidney transplant anywhere in the Western world, in the civilized world.
How do we compare to Guatemala?
We're good. I don't know what the problem is with those Guatemalans, but they could learn a thing or two from us. So why is that? Why are things so bad in BC? Well, it's multifactorial, obviously, but an important reason is the declining numbers of deceased donor transplants that we're doing. This is data over 10 years that shows the number of deceased donor transplants that are actually done in BC, and we can see there's a definite decline. There's a drop to about half of what we were doing 10 years ago. You can see that Ontario and Quebec are more or less holding their own, but BC is in decline. And this is just another way of looking at the same piece of information. If you look at organ donors as a rate per million population, which is a flawed statistic, but it's what's most commonly cited. You can see the rate, which is in the dark bar for BC, is about half of what the national average is. Now you can also see the light bar, which is the rate per million for living donors. We actually lead the country. We have the greatest rate for living donor transplants. And that's generally been our response here in British Columbia. We've usually emphasized live donor transplant, and what's driving that is probably the low cadaveric donor rate. This is something we're quite proud of at St. Paul's. We had a good year last year. And this is the live donor transplant activity for different institutions through the country. We actually led the country last year in numbers of living donor transplants. It's always been St. Mike's or Toronto General that did the most, but last year we had 59, which actually exceeded the Toronto group. I do want to take a moment here to just personally thank Ryan Patterson, who was a big part of this. Although Ryan didn't do in 2006 many of these transplants, he taught me how to do the laparoscopic surgery. So I thank Ryan for that, and this wouldn't have been possible without him. So we did the most in the country. I think it would be nice for me to say that we did the most because patients just thought so much of us that they were lining up to donate their kidney to St. Paul's Hospital, but probably it's the low deceased donor rate that's driving that. So the waiting times are excessive, and our patients are fairly well informed. They know information like this, that patient survival on dialysis, if you're a 65-year-old person who's starting hemo or peritoneal dialysis, taken all together, that group, your chances of being alive in 3 years are not good. 48%, 36% if you're on peritoneal dialysis. And our patients know that. And they also know that if you're 65 years old and you're facing dialysis but you actually get transplanted instead, that your chances of being alive at 3 years are substantially better. Even the subgroup who are diabetic, they do much better with transplant. So there's definite survival advantage if you actually get a kidney. Patients also know this, that if you eventually get a kidney but you've been on dialysis for some time, the outcome is worse. The outcome is much better if you don't wait. This event-free survival means event-free is you didn't die and you didn't go back onto dialysis. So if you get your kidney transplant preemptively, never needing dialysis, you do the best, clearly the best. Whereas if you've been on dialysis for 2 years, your chances of losing the kidney or dying are substantially greater. There's probably a number of reasons for that, but one interesting finding is that you're actually much more at risk for rejection if you've been on dialysis for some time before you transplant. Nobody really knows why. Some hypotheses about that, but basically it's not really known why that is. So what do we tell our patients? It's hard to say something intelligent when we have a 65-year-old person who's facing dialysis. It's they need a transplant. They should have a transplant. They're going to live longer. Their quality of life will be better, and it's cheaper. But they don't have a donor. So what do you say? It's hard to say something intelligent. And it's certainly hard to be judgmental if they were to pursue the option of going abroad to purchase a kidney. One response, the various responses that we have undertaken here are outlined in this slide. There's a donor exchange, which I'll describe, and anonymous donors, and Chris will discuss expanded criteria donors and donation after cardiocirculatory death. But these are all responses to the long waiting list. These are ways of just finding a kidney for some people who wouldn't otherwise have a kidney. So donor exchange is a concept that was introduced in the late 1990s. And Lainey Ross, who's a pediatrician and a medical ethicist in the University of Chicago, wrote a commentary in New England Journal outlining the idea in 1997. And this is it. The blood group A donor who would like to but cannot donate to blood group B recipient could still potentially serve as a donor if they were willing to swap their kidney with another blood group incompatible pair. So this idea was novel, and this commentary was published in an effort to generate some discussion before the actual program started. And these are the objections that were raised. The legal statutes that govern organ and tissue donation in Canada and the United States all use the same language. The organ and tissue donation are legal gifts, and as a legal gift, there can be no valuable consideration, quote unquote. What valuable consideration means is you can't get paid for it. You can't donate your kidney with the expectation of getting something back. And this, of course, is maybe exactly what these people are doing with the donor exchange. They're donating your kidney with the expectation of getting something back. So there's some concern about the legality of the whole idea. There were some ethical concerns. The idea of blood group incompatibility was always considered a very honorable excuse for people who had volunteered to donate but who were somewhat ambivalent about it. And It doesn't happen often, but it does happen where kidney transplant programs are required to help donors extricate themselves from a donation that they don't really want to do, and so they are sometimes called upon to fabricate some excuse, and blood group incompatibility is an honorable way out, even if it's not even true. But if you it's dishonorable for us perhaps, but if we're looking after our patients, that's what's sometimes been used. And if this idea of donor swap is now in place, then, and everybody knows it, then you can't simply say, well, this patient's incompatible, because the intended recipient could simply claim, well, you could swap and I could still get the kidney. So we've lost a useful excuse, useful to some programs. And then there's the idea of asymmetric outcomes. What if you donate your kidney, it goes somewhere else, your loved one, your family member gets a kidney back, and the result is not good? How would a donor feel? How would the recipient feel? Would they feel that they were used somehow, and that if the other recipient who received their kidney did better, had they been taken advantage of? So those are some ethical concerns. And then the practical concerns, such as the need for simultaneous surgeries. Another important principle is that the donor can always back out at the last second. The donor is always allowed to change their mind until they're asleep on the table. And so since it's pretty high stakes, this idea of donating and two donors swapping their kidneys, and since one can always back out at the last minute, it's important that they both be done at the same time. So that's a practical concern. And then there's the need for anonymity, which most programs who do this feel is important. So all of these are concerns. None of them are considered showstoppers. They're concerns, and so they were raised and discussed, and because the need for kidneys was so great, these were all felt that we could live with them. So far, so we've initiated a program. We're acquiring a population of patients who are willing to be involved in a swap, and Dr. Nguan and I have just did our first one not too long ago, perhaps a month ago. So we've actually initiated that program. We do have that available for our patients. There's some nuances to it. You can increase the number of living donor transplants if you're willing to consider patients not as two pairs but as a population. This slide sort of describes that. If you look at the first two donor-recipient pairs, A and B, you could simply swap kidneys, and that would be you could transplant those two people, and that would be fine. But if you look at your population, you may have other people who have willing donors, but who are sensitized against their donor, who have antibodies and cannot receive from their intended donor. And if you're willing to consider the whole population at the same time, it's possible you can mix and match kidneys and get everybody transplanted rather than just the first two. So this is a way of optimizing the donor exchange, and the larger your population, the greater the number of matches that can take place. There was a recent transplant in where Hopkins where they did five pairs, and to do them all simultaneously, of course, is five surgeons, 5 ORs, but that's Hopkins. And the whole idea is to optimize the number of people who are getting a living donor. There's another nuance is the idea of list exchange, where you have a donor and an intended recipient who is blood group incompatible or cross-match positive, and you can't donate to them, but you donate to the waiting list. And so someone donates to the first person on the deceased donor waiting list, and with the understanding that their intended recipient then becomes first on the list for the next cadaveric transplant. So we've not done that yet here, although I don't think that's considered ethically too difficult, because you increase your number of kidneys. The people on the waiting list are not disadvantaged because the waiting list gets a living donor kidney, and the intended recipient's time waiting is minimized. So it's not an ethically difficult idea. So this is something that we've not yet done, but we may still do. The next idea is anonymous donation, and this is something that was noticed through the early years of BC transplant, that every year they would get between 5 and 10 phone calls from people saying, I want to donate a kidney to anybody. I don't know anybody, but I want to donate. And they would always be told, well, we don't do that. Thank you, but we don't do that. But that was rethought about 6 years ago, and the anonymous donor program was initiated as a study, really. But this is now something that we would be willing to consider. Anonymous donation. A typical anonymous donor is somebody who has a history of altruism, and they often have a story to tell about how they knew somebody at some point who needed a kidney, or they were thinking about being a donor, but then somebody else donated to their loved one, and they still want to do it. There's often a connection to kidney donation, but they also, at least the good ones, tend to have a history of altruism. They're bone marrow donors, they're blood donors, they're volunteers in their community. So there are people out there that are willing to do this. There's not many, but they're out there, and not all of them are crazy. The two principles that are important for anonymous donation are, number one, that anonymity be maintained. That they're not. I think one of the fears is that these people may be somehow trying to inject themselves into the lives of the recipients, and we need to protect our recipients from that. We all fear the story of someone donating a kidney and then trying to perhaps extort money from the recipient afterwards. So anonymity is a very important issue. And then the issue that it be non-directed. The other name for anonymous donor is non-directed donor, and it has to be non-directed because there's always stories in the media about children or people with a compelling story about their renal failure, and if we allowed people to direct where their kidney went, then it really wouldn't be fair to people who weren't children, who didn't have a compelling story. They'd never get these anonymous donor kidneys. So if someone's going to donate anonymously, they have to donate to the waiting list, and whoever's first on the list gets the kidney. Those are the two important principles for anonymous donation. And this is we were the first in the country to do this. We weren't the first overall. It had been done in Minnesota, had done a number before us, but we were the first in the country to do it. We've done 3. The devil's in the details, as you can see. We are not a big program, and for me and my coordinator to assess 24 people to get 3 kidneys is not a very good use of our time. The 52 original subjects are 52 people who had spontaneously called in and expressed interest. 43 of them were, at the time this slide was made, 43 were actually approached and asked to start an assessment, and many of them thought better of it when we actually called them back and said, why don't we do it? But 24, about half were willing to actually do it. At 24 said, sure. And many of them were either withdrew or were found to be unsuitable. But we did do three transplants, and the jury's still out about whether this is a program that's going to survive because of the amount of time and resources that are required. It's easier to just do transplants from people who are compatible. And that's a good use of my time. I I see a donor, I see a recipient, we do a transplant. It's efficient, but we do have a need and a requirement to help the patients who don't have a living donor or don't have an obvious living donor. And these are the two initiatives that we've undertaken to at least start that process. With one swap done and 3 anonymous donors, we're not going to solve our problem with those numbers, obviously. But we hate to see a kidney go to waste, and we're so far going to pursue and try to expand these programs. So I'll stop there. That's the living donor initiatives. I'll let Chris talk about the deceased donor initiatives and ways that we can actually make a real difference in the number of kidneys that are done.
Thanks, Bill. So we'll be talking about the deceased donor strategies for increasing the donation rates. I talked a little bit before about expanded criteria donor to the same audience, and just go over the kind of BC transplant strategies specific for ECD guidelines, as well as this idea of donation after cardiac death, which is a newer idea, especially for Canada. So some of this data, again, comes from the core report, 2006. And as Bill showed previously, in 2001, living donation finally surpassed deceased donation as the most common renal transplant type in Canada. And that trend continues to increase, and I don't think it's ever going to go back. And again, same slide as Bill showed, but again, just to document that BC has the second lowest deceased donation rate in Canada, only behind Manitoba. Should be proud of that. And in terms of comparison in the rest of the world, again, we have a very low rate per million of overall organ donation rate. You can see us compared to the U.S., we're almost half of them. France, again, extremely high donation rates. Spain is mandatory donation or default donation, so that's why their rate is so high. And you may be familiar with this graph, which basically shows the wait list versus the number of transplants, renal transplants performed through the 5-year period, 10-year period, 95 to 2005. So the wait list continues to remain stable, while the number of transplants slowly increases. Now, this flattening of this curve is completely artificial and primarily represents a capacity effect of our waitlist program, in that we're just not able to support and maintain an ongoing and ever-increasing number of patients to be added to the waitlist. So patients are being added and falling off at a continuous rate to establish an equilibrium. There's no point adding more patients to the list when you have a 5 to 10 year list, because those patients will never get transplanted and you're burning up resources. So that's the primary reason why programs have, as a need for their resource management, curtailed addition of patients to an extended waiting list. And this is data that's a summary from CORE's waitlist analysis. In 2005, there were almost 4,000 patients waiting for an organ transplant. That's any type of transplant. And the majority of those were waiting for a kidney transplant. This comprised 69% of the waiting list, so almost over 2,500 patients. And the cost of a prolonged waiting list is really measured in patients dying waiting for a transplant. And in 2005, there were 275 people that died on the list. Now, most of those were waiting for a liver because they're obviously very sick patients with liver failure. But 67 of those were waiting for a kidney. And as Bill showed you previously, I mean, there are lots of reasons why patients are dying on the waiting list. They're waiting on dialysis, and dialysis has a certain mortality associated with that, especially as you continue. So it's no wonder that it's actually pretty good that we have such a low death rate on dialysis, but still, it's there, and it'll be ever increasing as our dialysis capacity increases. A subgroup analysis of the same type of data, you can just see breakdown by year on dialysis and wait list, basically. not really waitlist because some of these patients on dialysis are not actually eligible for transplant, but survivability on dialysis is age dependent. So as your population increases, for example, our population in Canada, as the baby boom bulge moves up, those patients, a certain proportion of them will end up on dialysis, and they'll be older, and as a consequence, their mortality increases. Breakdown by disease type shows that renal vascular disease and diabetes lead to the highest mortality on dialysis as a cause. So in order to address waitlist issues and trying to increase deceased donor rates, there's two main strategies: extended criteria donation and donation after cardiac death. And I'll talk about these just briefly separately. Now, I'm sure most of you have seen this table. It basically is a summary of the UNOS, the United Network for Organ Sharing in states, which oversees all the transplantation in the states. And what Ojo did in, I think it was 2001, he looked at the SRTR database, and he looked at those patients who had a 70% greater death-censored graft failure rate, and identified factors which contributed independently to that. And what he found was that a elevated creatinine, a diagnosis of hypertension in the donor, or a death by cerebrovascular accident were all independent predictors, as well as age greater than 60. So if you are a donor, if you're a deceased donor, and your age is greater than 60, you're automatically considered an extended criteria donor. The organs that that donor gives up have a 70% or 30% greater failure rate versus ideal donor kidneys by definition. If you're greater than 50 and have one of these items, then again you're considered extended criteria. Sorry, two or more of these items, they are considered extended criteria. So this is based on definition of ECD. That is what the UNOS definition is. So the question has always been, and continues to be passed back and forth, of, well, we know that these kidneys have a reduced survival. So will people actually accept them? And if they do accept them, will they last as long as predicted according to registry data? So the question is, should a patient on the cadaveric list accept an ECD kidney? And again, a retrospective review of the same database on a validation cohort of 122,000 patients showed that there is a separated, as expected, survival time of the graft, favoring ideal donor kidneys, of course. And when you look at this following transplantation, you see that there's only a survival benefit for ECD kidneys versus dialysis after almost 6 months of transplantation. So you have to have your transplant, you have to overcome all the complications and side effects of the immunosuppression and titration and all that stuff for 185 days before you really hit the break point of dialysis. But once you get over that, there is a over 5-year improvement in life expectancy over waitlisted patients. And this data here is pulled out of BC Transplant's own data set. And what basically is showing here is the total kidney donors are seen in blue, and the total ECD donors are seen in red. And although the data is hard to trend because of the variable numbers and the relatively small numbers, you see that ECD is a component of our donation rate. It's hard to analyze this 2005 year because of the overall low donation rate. And proportionally wise, it doesn't fit into the trend, but I think globally, ECDs are becoming more and more of the overall deceased donor pool. So in terms of the ECD strategy, they do have a lower graft survival rate than ideal donor kidneys, as defined by the original reason that they were invented. But they are useful for certain patients at risk on the waiting list, and those patients generally, on re-review of this issue by the same author, Ojo, would be patients who are older and patients in a program which is not perhaps as active, and therefore they'd be waiting longer. And in BC, the ECD kidneys comprise up to 35% of last year's, or 2005 years of total numbers of deceased donor transplants, and it's expected to continue to be a major component. In terms of donation, deceased donation, currently our donors are all considered brain dead. So it's not a cardiac death, it's a brain death issue. So they maintain a cardiopulmonary state, or we are able to maintain a stable cardiopulmonary state for donation. And the criteria for brain death would be things like GCS3, absent brainstem reflexes, positive apnea test, and absence of blood flow to the brain documented by EEG, nuclear scan, and angiography. So we're currently attempting now to look at cardiopulmonary death as a possible avenue for retrieving donors. And UNOS has identified criteria for identifying possible DCD candidates. The Maastricht criteria define deceased donors according to 4 different categories. However, for the purposes of organ donation, we only consider controlled cardiopulmonary death as an avenue for organ donation. So basically, we're talking about patients in the ICU who will not be able to maintain their own life support systems if taken off the ventilator and so on, or IABP and things like that. So UNOS has gone back. They've looked at ICU criteria of critically ill patients and identified these criteria which predict patients who might be eligible for a DCD program. For example, if they have apnea on the apnea test or certain other respiratory parameters indicating that they would fail off the ventilator or failing extubation, if they have assist devices of the heart or on ECMO, if they have significant other ventilatory requirements, not just rate, if they're on significant numbers or amounts of pressors, or if they have an IABP plus major circulatory support, which, if turned off, would not allow them to survive. So it's a bit of a morbid process to look at this stuff, but I mean, we need to know patients who would be eligible versus patients who would not in order to identify those patients to be brought to the OR. And certain principles that have to be applied to DCD, and the first thing that you need to make sure is that this, as a program, this is a strategy to preserve life, not to basically hasten the conversion of an organ donor, try to collect more donors. We don't want to be seen as vultures in the ICU waiting for people to die and then jumping on them. We want this to be a process whereby everybody knows that we're trying to save 7 lives or improve the 7 lives with the death of 1 person. And as part of those principles, I mean, I listed a few of the points that are listed on multiple different policies and procedures of the major programs such as Pittsburgh, UCLA, and Miami. So obviously, care of the living is never compromised for trying to find a donor. The interest of procuring organs does not interfere with optimal patient management. That's management of the living. Consideration of organ donation is done only after the decision to withdraw or withhold life support and the family is interested in donation, so that has to be laid up front. Organ procurement is immediately aborted in the event of if patient death does not occur following removal of life support or if organ ischemia is prolonged. So therefore, a strict diagnosis of cardiopulmonary death must be made, and any protocol, however well scripted, this is the end line of a lot of these policies, explicitly prohibits any intervention whose primary intervention is to shorten the patient's life. So the patient must die of a natural cause, essentially, following withdrawal of medical life support. And obviously, the policy must promote and enhance public trust. And DCD is a very touchy subject, and this is one of the primary tenets. In terms of the technical details, the patient must meet the following criteria, and these are currently under development by BC Transplant. These criteria come from Pittsburgh. The patient must, in terms of ventilation, spontaneous unassisted ventilation is associated with prompt and severe desaturation, incompatible with life. They must be unresponsive and unreceptive with no response to noxious stimuli. And any reversible conditions mimicking coma must be excluded. If the patient meets these criteria, then they're brought to the OR, of course, following consent and so on. They're brought to the OR for withdrawal of life support. So the patient is taken from, say, the ICU or CCU, brought to the OR, still ventilated, still intubated, still on any type of life support that they're on. And at that time in the OR, the life support is withdrawn under controlled conditions. After that, a diagnosis of cardiac death must be made accurately and promptly. The Society for Critical Care Medicine states that a diagnosis should not be made in less than 2 minutes and should not exceed 5 minutes. So there's a very narrow window inside which to make that diagnosis. Now,
Chris, can you just comment, would the intensiveness of the country support transplant in this process? And do they support it locally? In other words, are they part of the process? Or is this still an independent transplant-based idea?
in terms of intensive care buy-in for transplantation in general, it varies across the province and varies locally as well. Those programs that are heavily deceased donor driven obviously have a lot of intensive care support. So a lot of eastern provinces such as Atlantic Canada, Quebec, and Ontario, they have very good intensive support. Out west or in living donor programs such as here, perhaps our ICUs are not quite as on board. It's a lot of that is related to resource issues and bed management, because ICUs don't want to tie up beds for organ donor assessment while they have critical patients in the emerge trying to get into the ICU or in PAR and so on. So it does vary. In terms of DCD, only Toronto and Western have gone with this program so far. So a diagnosis of cardiac death must be made quickly, and a diagnosis of this is greater than 5 minutes of asystole, absence of ventilatory efforts. And if a diagnosis is made, then the procurement team, which is in the OR at that time, will immediately begin the procedure. And the procedure is basically an insertion of a femoral perfusion cannula with a double balloon system and the whole body perfusion with preservation solutions such as UW or HDK. The other option is an immediate open operation for great vessel cannulation as per the standard deceased donor retrieval technique. In terms of outcomes, you can see here standard criteria donors, ECDs that are not DCDs, DCDs which are not ECDs, and then the combination of DCD and extended criteria donor. This breaks it down into a percentage of DGF associated with these types, and it is basically increases, and the 1 and 3 year survivals. So overall, if you look at standard criteria donors, their 1 year survival is 90, 3 years 80, versus regular ECDs, which is 72 and 71. And then DCD survival rates are actually very good, 89 versus 90 and 80 versus 80. If you combine DCD and ECD, there's a slight hit, 81 to 90 and 70 to 80, which is pretty much expected. But you can tell that with an integrated program, DCD donors can work, and they can be expected to have good outcomes. There is an issue of how to improve the high DGF rates associated with delayed graft function rates associated with donation after cardiac death. And one idea is to pump them. So this is a machine that circulates perfusate solution through the allograft after it's been removed from the body. And this is an attempt to flush out more of the blood and try to preserve it better and so on. They've tried this in standard criteria donors and have not shown a big difference. But because ECD and DCD donors have poor outcomes, they revisited the idea of pulsatile perfusion of the allografts ex vivo in an effort to improve their outcomes. And they have shown, if you look at non-DCD non-pump versus non-DCD pumped, that you can reduce the DGF rate. And if you look at DCD donors, not pumped versus pumped, there is also a slight reduction in DGF. This is great news for the manufacturers of these devices, such as this device, which looks like a Coleman cooler, which is all computerized, and the kidney and the cartridge. You can't really see it here, but again, it's another consideration for programs who wish to go to DCD. In terms of a summary for DCD and BC, we're currently developing protocols and procedures for this type of program. It's being drafted in parallel to all other strategies. We already have purchased 2 LifePort pulsatile perfusion machines for this purpose. The estimated impact on the donation rate, because there's no point in undertaking such a large program, initiation of a large program, if there's not going to be a good turnaround, is between 5 and 10 extra donors per year based on our current numbers of deceased donors. However, a note should be made that some programs in the States have increased their overall deceased donation rates up to 30% or more. So this can potentially have a very significant impact on our cadaveric donation rate. So obviously the concept of ECD kidneys is well established. We in BC continue to use them with good results. In fact, as a program, we're developing an old-to-old policy now, where ECD kidneys, which are known to have a poor outcome, are given to patients that perhaps don't have as long a life expectancy for another reason, age, comorbidities, and so on. Instead of giving a poor quality kidney to an 18-year-old, we might give it to a 60-year-old. So to try to match up both sides. BC is also developing a DCD program in parallel with all other strategies to increase the donor pool.